Hello and welcome to this episode of the VJHemOnc podcast, where we are spotlighting advances in the understanding and treatment of Waldenström's macroglobulinemia, a rare and slow-growing form of non-Hodgkin lymphoma. To begin with, we will focus on the impact of MYD88 and TP53 alterations. First, you will hear from Karan Chohan, who comments on a recent study investigating the distinct epigenetic profile of MYD88 wild-type Waldenströms, followed by Treon, who comments on the prognostic significance of TP53 mutations.
So MYD88 wild-type Waldenström's macroglobulinemia represents about 10% of patients with Waldenström's. And currently, we know from the clinical papers that these patients are at higher risk for transformation, and they have poorer response to the traditional BTKi-based therapies that we currently use. The paper we have and we're presenting today is focused on the epigenetics of MYD88 wild-type Waldenström, specifically the non-coding epigenetics. The two aspects we're interested in are looking at DNA methylation as well as microRNAs. And what we did for this project is compare the methylation profile and microRNA profile of patients with wild-type disease compared to those who have mutated disease, and patients with wild-type compared to those who are controls or healthy controls that we saw at Mayo Clinic. What we found from this project was that firstly, patients who have MYD88 wild-type disease have hypermethylation across the genome, and that's both in coding and non-coding regions. And additionally, when we combine that with pathway analysis, looking at our mRNA expression, we found that several pathways involved in cytokine regulation, intracellular signaling were downregulated in patients with wild-type disease compared to both mutated as well as controls. On our microRNA analysis of patients with wild-type disease, we saw that there was several transcripts that were differentially expressed compared to mutated as well as healthy controls. And importantly, what we saw is that one microRNA in particular, miR-138, which regulates DNMT3A, as well as DOTAL1, which are involved in DNA methylation, was differentially expressed as well. So altogether, this shows us that MYD88 wild-type Waldenström is distinct from those of mutated disease. And epigenetically, especially the non-coding epigenome is different in these patients, which may underlie the biological as well as clinical phenotype we see.
So we recognized at the last international workshop on Waldenström's that patients who have TP53 alterations, and that includes both mutations in TP53, but also loss, 17p deletions, are very, very indicative of high-risk patients. And what we're also seeing is that patients who had received perhaps earlier in their course of therapy alkylators also appear to be at higher risk of acquiring these mutations. And that's why I think, the last consensus panel that was held at the workshop in Prague identified TP53 alterations as being indicative of high-risk disease and worthy of us concentrating. Now, do we have really an action plan around these? A little bit. We know that zanubrutinib is more active than ibrutinib. We tend to prioritize zanubrutinib for treating patients with TP53 alterations. But I do think more is needed. And perhaps now with the excitement around cellular therapies, we may be seeing a path forward for treating and managing these patients with high-risk disease.
We will now turn our focus to current treatment approaches for Waldenström's. Dr. Treon joins us again to discuss the approach for patients with symptomatic treatment-naive disease, highlighting the role of BTK inhibitors. Dr. Chohan will then share insights into the long-term outcomes of patients who discontinue BTKi therapy, followed by Anna Maria Frustaci, who comments on salvage treatment strategies after covalent BTKis.
For treating symptomatic treatment-naive patients, we tend to prioritize BTK inhibitors. Really, our approach to treating patients is that do no harm. And we are concerned about long-term, consequences of alkylator therapies. We did hear at the last workshop on Waldenström's in Prague, the update on the long-term results of the PHILO study from France of patients who got bendamustine Rituxan as their initial therapy. And the concern around that study was half the patients had long-lasting cytopenias, and 18% of patients had secondary malignancies, some of which might be age-related, but treatment-related MDS and AML were also described in their study. So do no harm is very important, especially in a disease like Waldenström's. We have now non-chemotherapy options, non-alkylator-based options. So this is our priority for treating treatment-naive patients. But for patients who might have bulky adenopathy or amyloid, we do consider bendamustine as well as proteasome inhibition. In previously treated patients, it really comes down to what the patients have seen beforehand. Again, if the patient hasn't seen a BTK inhibitor, consider that. But if the patient has progressed on a covalent BTK inhibitor, just know that pirtobrutinib as well as venetoclax are very, very active agents. And always think about a clinical trial, because the only way we're going to make progress is by getting patients on clinical trials.
So this is a study conducted at MD Anderson where we looked at all patients over the past 10 years treated with BTK inhibitor therapy. We included all patients who received at least one cycle of therapy. And what we found was that amongst patients who discontinued therapy, about half of the patients discontinued because of adverse events. Majority of those were infections, cardiopulmonary toxicity, importantly, bleeding, as well as atrial fibrillation. And the other half, about a quarter, discontinued due to transformation or disease progression. And another quarter discontinued because of patient or physician preference. Amongst those who discontinued and received a subsequent line of therapy, we found that if the reason for discontinuation was progressive disease, the outcomes are fairly equivalent based on the next line of therapy. Next line of therapies included a combination of rituximab with chemotherapy, another BTKi, venetoclax, or some sort of other clinical trial-based therapy. And when we looked at progression-free survival and overall survival outcomes in those patients, outcomes are fairly equivalent amongst those groups. So the overall response rate around 60%. Specifically, if we looked at all patients who discontinued and then received another line of therapy, that's including those who had an adverse event, we found improved PFS outcomes with a second BTKi. So the important takeaways were, if a patient discontinues because of an adverse event or other reason, it's reasonable to consider another BTKi-based therapy. But if they have disease progression on a BTKi, we see pretty equivalent outcomes with the next line of therapy. So there's a number of different options that can be selected for these patients.
Okay, this is a great question because the salvage treatment after covalent BTK inhibitor in Waldenström macroglobulinemia is really an unmet clinical need. We don't have a well-known strategy to treat these patients. We just know about phase 1 and phase 2 studies. So at the moment, we can use as salvage treatment no covalent BTK inhibitors. This is supported by the BRAWM trial that explored patients with Waldenström. A cohort of patients we previously treated with covalent BTK inhibitors that responded well to pirtobrutinib. We have about 22 months progression-free survival in the whole cohort, so including exposed and not exposed to covalent BTK inhibitor. But of course, this is an effective strategy because we know that patients that relapse with BTK mutation covalent BTK inhibitor may respond to non-covalent BTK inhibitor. Another strategy could be the BCL2 inhibition. This was explored in a phase 2 study from the Center of Boston with the venetoclax monotherapy. But there are currently some ongoing trials also with sonrotoclax, that is a next generation BCL2 inhibitors. And also this pathway would be an effective strategy for patients relapsing after covalent BTKi.
As Dr. Frustaci mentioned, there are several ongoing trials investigating novel treatment strategies for this disease. In this section, you will hear from Neil Berinstein, who shares the results of the BRAWM trial, which is evaluating the combination of bendamustine, rituximab, and acalabrutinib for frontline Waldenström's. Cheah then goes on to discuss outcomes of sonrotoclax monotherapy in relapse refractory cases.
We're very pleased with the results of the BRAWM trial. That's what we're presenting at the ICML in Lugano currently. And the results are very positive. We see the highest response rates ever seen in Waldenström's for first-line treatments. The complete and very good partial response rate is over 60%. And historically, the rates have been closer to 20, 25%. So we've actually doubled the complete and very good partial response rate. we see that we're getting deep responses because complete and very good partial responses are by definition almost very, complete responses. And we're also backing this up with very high rates of minimal residual disease negative results in patients' peripheral blood. Not so much in the bone marrow, but definitely in the peripheral blood. The MRD negative rates at our first response assessment was very close to 70% to 80%. Now, I think that these results are important. We'll have to see how it plays out and whether these very deep initial response translate into longer durations of response. But one thing we're very excited about, and we've looked at this very carefully, is that patients who have very high risk Waldenström, so patients who have mutations of CXCR4 or who have wild type MYD88, these patients are known to have poorer response rates to standard treatments and shorter response durations. These patients behave very similarly to all other patients in our trial. They had the same response rate. There was no difference in response rates or MRD rates that we were able to document in these high-risk subgroups. So it could be that patients with higher risk Waldenströms would be ideal candidates for this type of combination treatment where we combine several different treatments together.
The sonrotoclax data in Waldenström is also encouraging. I mean, this is a drug which is highly potent in a range of B-cell malignancies. We know that venetoclax has some activity in Waldenström macroglobulinemia, but we've updated the results of sonrotoclax in about 24 patients with relapsed and refractory WM, and we're continuing to see increasing depth and durability of responses there. The activity has been sufficient that this is now moving forward into a phase 2 study in Waldenström macroglobulinemia called the 203 study, for which enrollment continues.
Finally, we focus on studies investigating BTK degraders in relapsed or refractory disease. Dr. Frustaci shares updated data on the safety and efficacy of BGB16673, followed by Dima El-Sharkawi, who discusses phase 1 results of bexabrutideg.
So in the last EHA meeting, I presented the data on BGB16673, that is a BTK degrader. So this is a new concept of BTK inhibition in which these agents actually degrade the BTK, both the wild type and the mutant form, by tagging BTK for degradation through the cell proteasome pathway. In the last follow-up at 8.2 months, we observed that these agents had a significant preliminary antitumor activity that was demonstrated by a high efficacy with an overall response rate of 84% and about 1/3 of patients achieving a VGPR, so a deep response. And these responses were really rapid. We could see it by the time to first response. This was in median 1 month. And the significant improvement in responding patients for cytopenia. So they showed a recovery of cytopenia in about 2 months of treatment. So all this data, in particular in this kind of population of heavily treated patients with enriched for high risk genochemic aberration for Waldenström, support the use of these drugs in the setting of relapsed refractory patients with Waldenström after current BTK inhibitor.
So bexabrutideg, or NX-5948, is a BTK degrader. So we've all been using BTK inhibitors in our everyday clinical practice. So the covalent BTK inhibitors first came along, then the non-covalent BTK inhibitors. But we think BTK also, as well as having enzymatic activity, probably plays a scaffolding function within the cells. And so by degrading the protein, you're not only removing the enzymatic activity, but you're removing the scaffolding function as well. And so we know that BTK degraders potentially could work even in patients whose disease has become resistant to BTK inhibitors. So there's currently a phase 1 trial that we're participating in looking at the use of NX-5948 across a range of B-cell malignancies. And at EHA this year, we're presenting the data from the patients who have Waldenström. So it's just over 20 patients who've had the NX-5948, and the response rate is really encouraging. So over 80% of patients responding. The response is quick. So average time to response is less than a month when we start to see already patients' disease improving. And obviously it's an early phase trial and it's still relatively short follow-up, but there have been a few patients that have had the treatment for over a year and are still getting durable responses. So still very early days. Looking forward to seeing the expansion cohorts to see its effect in more patients and to see the development of the drug across B-cell malignancies, but really encouraging data from this trial so far in WM.
That's all the updates we have for you today. We hope you found them useful. Don't forget to follow us on X at VJHemOnc and subscribe to our podcasts on Spotify, Apple, or Podbean. Until next time.